we can have some ability to predict which patients will get more or less benefit. That is doing a test on the tumor cells called PD-L1 testing. It's a protein, as I mentioned, that tends to be associated with a better response to all of these classes of drugs. But it's not a perfect test. You can have high-level expression of the target and still not get a great result. You can even have low or no level of expression of the target on the tumor cells and occasionally get some good results. But yes, there's a correlation. If people have high level of expression of this PD-L1, we typically will give an immune therapy, pembrolizumab or Keytruda, as a first treatment. Now, an exception to that is patients with a driver mutation, like an EGFR mutation or an ALK rearrangement. In those patients, we have not favored giving immune therapy first because our targeted therapies are so effective with response rates in the range of 60 to 70 or 75% rates of tumor shrinkage in patients that we have considered the targeted oral therapies to be a better option. In contrast, though, these immune therapies can be effective even in our most cherry-picked selected patients. We're talking about a 50% tumor shrinkage rate, which is really quite good, but it's not as good as the targeted therapies. It's important to also bear in mind that we need to prioritize competing options. And for some patients, immune therapies are not going to be a high choice. One reason is, as I mentioned, there is some correlation between the level of PD-L1 protein expression and the probability of a good response. We generally give immune therapy as a single agent only to the people most likely to respond well to it, and we might relegate it as a second line or even later treatment to patients with low level or no PD-L1. Many of the patients who have a driver mutation, maybe even most never smokers, don't tend to get as much benefit from these immune therapies as patients with a significant smoking history. It seems that the patients with a long tobacco exposure, that often leads to many mutations that all contribute to the development of a cancer, and the immune system seems to have a better ability to recognize many mutations traveling together than one ninja mutation that can elude it. So we tend to see the best results with immune therapies in the smoking-related cancers, or certainly the ones that are not associated with these driver mutations, EGFR and ALK, etc. This doesn't mean you would never try an immune therapy for those patients, but it does mean that you would really prioritize it later, at least after you have exhausted your targeted therapies, and often considering it as after you've completed chemotherapy and one of your later treatment options. You can see a response, but you really wouldn't prioritize it that highly in that setting. There's also patients who may have immune issues, and that can be something very serious, multiple sclerosis, for instance, or severe ulcerative colitis or something where the immune system attacks the colon. These are situations where you do not want to stimulate the immune system. It could be disastrous. There could be patients who just have mild rheumatoid arthritis or some other things where you might consider it, but it's always something you'd want to give careful consideration about the potential negative consequences, because we know that somewhere around 15% of patients will have problematic autoimmune disease already. So stimulating that could be like pouring gas on a fire, and we need to be mindful of that risk. So immunotherapy is a wonderful tool, but it's not the right tool for every job, and particularly for the patients with a driver mutation, it's really one that we would tend to relegate to later treatment and strongly favor a targeted therapy for those patients.